Hello and good evening, everyone, and welcome to this webinar on ultrasound guided versus guided injections, advancing precision in practice. And in today's session, we are joined by sports and exercise medicine consultant, Dr. Harj Singh. A quick introduction to PhysEquip for those who might be new to us this evening. We supply specialist MSK technologies and education with the mission of bringing us. We'll start the mission again. Should know that. So a quick introduction, obviously with our mission being to transform the MSK industry by inspiring growth and bringing people together in the MSK community, which is hopefully what we do with these webinars and our education and speaking with people in the field like Harj. So Harj is going to be delivering a presentation this evening, which then will be followed by a Q&A covering some pre-submitted questions that we've received. So thank you for those. And if you are listening live, then please pop some questions on the Q&A tab and we can get around to answering those as well. So with that, I'm going to hand over to Harj for the presentation.
Well, good evening, and thank you, Katie, for asking me to deliver this webinar. My relationship with PhysEquip's gone back a number of years when we had an ultrasound machine which was delivered to Leicester City, and more latterly I've been working closely with Dominic from the team at the UKSI in Sheffield at EIS, so we've been doing quite a lot of work there. So thank you again for having me on tonight. So just a little bit about me. I am a half-time NHS consultant, during which time I do guided injections once a week. So I do that regularly. In private practice, I do a number of interventions that aren't available within the NHS and within the novel therapies and regenerative medicine field. So, and my sporting footprint is I work with Leicestershire Cricket, UKSI. I do work with a number of professional boxers and also work with PGMOL, the refereeing organisation. Have nothing to do with their decisions or their eyesight, but I do look after them. And funny enough, this evening, I got a call for them. They needed an ultrasound-guided injection tomorrow. So, sometimes things happen very quickly, and you've got to have, hopefully, you can be able to help people out. And I work with a number of clubs locally in the East Midlands as well, second opinions, match day cover as well. So that's a little bit about me. And obviously, one of my passions is ultrasound guided injections. So part of what I wanted to do today is talk about research on how ultrasound enables you to deliver injections more precisely into areas of pathology and injured tissues, and also look at clinical outcomes, including pain scores, range of motion, between ultrasound guided and landmark guided injection. I'll show you a few images as well, and then we can go from there. And then sort of just an emphasis on how ultrasound can help to carefully place the needle, avoiding critical structures like nerves and vessels, so that reduces your risk footprint as well. So hopefully we'll go through this in quite a systematic way. But I am going to start off with a study from about 15 years ago, which put the case for ultrasound back a little bit. And that came from a group in Oslo, where they compared steroid injection to the subacromial bursa versus IM steroid, and that was for impingement rotator cuff disease. It was a randomized controlled trial. And in short-term outcomes, there was no difference in outcomes. So for me, that really put the case back for ultrasound, because people thinking you could give an IM injection and have the same results as carefully delivering steroid. But I think I'll show you some evidence which goes to the contrary with that. I think in medicine you can prove what you want to prove. So for me, I'm just going to go through some of the benefits of ultrasound, and then we'll drill down on the evidence. So I think it definitely gives you increased accuracy. So you're able to sort of then target the soft tissues. We've talked about minimizing risk. When I consent somebody for a procedure, I'm always talking about risk of damaging nerve blood vessels, adjacent structures as well. And sometimes, you have to also tell them if you are injecting into a tendon or ligament, that can actually make things worse. Real-time imaging is important, so you can look at the structures, you can avoid structures, you can look at new pathology which may be evident that wasn't seen on a scan before. So I think there's a number of things. One less confounder in recovery. People say it may be a placebo effect, but if let's take anything that works really. So visualization of the needle placement. In the sporting field and the sporting space, I think it's very important that you can document that. I save all my images and also report on packs, just in case something happens afterwards and there's an adverse effect, or somebody might say, well, actually, you didn't put the needle in the right place. I think some of the treatments that I offer are quite novel. They are expensive, so I think you want to get them in the right place to have optimal effect. There's lots of other factors that aren't variable in outcomes, but if you can put the injectator in the right place, that reduces one of the variables. I think better clinical outcomes. Patients tend to tolerate ultrasound-guided injections better than landmark-guided. I think part of it is you know where you're going. On occasions when landmark-guided, you have to keep on moving the needle, or you might have to go in a slightly different place. Occasionally it still happens with ultrasound, but not often. And the number of times I hear from patients, was that all it was? I'd be quite a rich man if the times people say that. So going on to this, landmark guided, and yet they have their place certainly, but there isn't that real time guidance. It can be inadvertent needle placement and lower efficacy. There was one study it's quite remarkable that 1 in 4 non-guided knee injections are extra-articular. I have to say though, the more you do non-guided, the better that becomes. So an orthopedic surgeon might say to me that I can get the joint every time. He probably can, but I could get it better with an ultrasound as well. So there is a learning curve with that. So I think there is a place still. In my own practice, I tend not to do any unguided injections. And I think some of the evidence that I'm going to show you today, we're in a landscape with private medical insurers that are trying to stop guided injections and producing evidence that the outcomes aren't any different. So I've got some evidence here, if you have to appeal with a non-funding decision. So there is that practicality of it. So the studies we're going to go through is the effectiveness of ultrasound-guided injections, pain reduction, improved function, and improved patient satisfaction. And I think that's what we're all in it for as well. So I am going to go regionally with this. So first of all, with the hip and groin. So this study showed that it's slightly weighted. Well, you can see it's weighted against landmark, 2-to-1 landmark guided versus ultrasound guided in the review. So and they said that 100% accuracy with ultrasound guided. Have to take that with a pinch of salt. I don't think anything's 100%. And 72% for landmark guided. Obviously, with this study, it didn't say, were there any adverse effects. There is neurovascular bundles, tendon as well. There's the recurrent circumflex artery that you have to miss. So the accuracy needs to be there, but also probably hand in hand with that is less risk and less side effects. So that shows 100% versus 72%. As I said, I would be a little bit reluctant to say anything's 100%. So we've got the next study here, and this was just looking on needle and tip visualization to minimize these risks. So it's quite a good study, just showing that. But that's for me, it's just important about needle and tip visualization. That can be difficult practically in hips because you have to oblique the needle rather than going parallel like we tend to want to, because you can see more of the needle. So I think trying to get that needle and tip is important, certainly. And sometimes you have to go deeper than you think. So I've relied heavily on this evidence from the European Society of Musculoskeletal Radiology, and they, in the early 2020s, made a number of statements about regional use of guided injections. Um, so for this one, first of all, slightly, better mix there. So intra-articular palpation guided was 67 to 88%. Ultrasound was 97%. So you can see there is a benefit, certainly. But during that consensus, they also looked at 10 evidence-based statements as well in there, from iliopsoas injections, GTPS injections, injections into the symphysis pubis as well. And they've also made some recommendations about the injectate, what's better and what's not. But I think for the purposes of this talk, it is about the guided injections rather than the efficacy of each medication or injectate. So they've also talked with the knee, strongly recommended it for intra-articular and patellar tendinopathy with PRP, platelet-rich plasma, Baker's cyst aspiration, I think for obvious reasons, Pezanserine bursitis. And again, Pezanserine is very difficult to see clinically. Ultrasound, it's not easy as well. So, and dare I say it, just going back to the hip, we don't have to go back on the sides though. If you have to do an iliopsoas bursa injection, aspiration, that's very close to the femoral artery, so you need to know where you are. So with the knee as well, this is a small study that looked at the efficacy of the PRP injections under ultrasound, and I think we're on the same sheet. Yeah, 185 knees, and the PROMs had improved, and also cartilage thickness and reduced synovial hyperplasia, so less inflammation and neovascularity. It's interesting about the cartilage thickness. I'm not sure that PRP in itself has that regenerative properties, although I think there is some claims to that. Okay, and then this is a review between ultrasound-guided and blind injection. So large numbers of patients in the MSK space. We've got 1,400 versus 1,300. And the ultrasound-guided injections were more accurate than blind injections. These chaps didn't report on outcomes, but we will talk about the outcomes and how that translates. And just on that note, with the knee, I just wanted to talk to you about an injectable implant that's relatively new to the market and has to really be done under ultrasound because it irreversibly binds to any of the tissues. This is arthrosomade, an implant that's used. And if it's not in the supratellar recess, it won't work properly, and there may be potentially adverse outcomes. So this irreversibly binds. How it works is irreversibly binding to the synovium. So, and they emphasize that ultrasound guidance should be used for the above reasons, notwithstanding how expensive it is as well. So if it's in the wrong place, it's a lot of patient money that goes down the drain. Right, so foot and ankle. So again, this is from these consensus statements from the great and good in Europe. So ultrasound guidance strongly recommended for plantar fasciitis, Morton's neuroma, any tendon sheath injection. I think to really get into a tendon sheath, you need to know where you are. And the only way you can really do that is under ultrasound guidance. And that was both for platelet-rich plasma, PRP, as well as corticosteroids. Interestingly, for ankle joint injections, there was no difference between landmark guided and ultrasound guided. Personally, I think there is a difference. The access point is slightly different to the ankle when you inject under ultrasound to try and avoid neurovascular bundle and tendon. So I can see it's a relatively easy joint to inject, but it's what the downside is if you're injecting, and I know people who inject anteriorly, where there is, a number of nerves and blood vessels there. The other thing they've suggested with the foot and ankle, certainly in the midfoot with multiple articulations, I think if you can carefully guide an injection, you know what you potentially able to identify the pain generator, and then if subsequent more definitive treatment is required, then I think outcomes are better there. The next paper I put on is more of an observational paper, and it's a good paper to look at the overview of injections, the repertoire injections, and dose of injectate for various joints. So yeah, that's a relatively new paper as well from 2023. So with the lower limb, this next study as well, again, it's an observational study. So I think it's good, the use of ultrasound-guided injection in lower extremities, and just the importance, joint aspirations injection, as well as, about the dynamic capabilities of ultrasound. So it is, you've got to see it, you've got to do it. Sometimes looking at an image from an ultrasound is very difficult because the image probably doesn't always do justice as what's going on at the time. So going to the upper limb, there's be quite a few bits here on the upper limb. This is, the ESSR consensus statement. There's 20 statements that they made. 5 reached the highest level. 10 were about tendon procedures, 6 about intra-articular, and we'll go into the details of those, and 4 about intrabursal injections. So first of all, so ultrasound-guided injection of PRP superior to dry needling in rotator cuff tendinopathy and also partial thickness tears. As I said, we're not here to argue the toss about what's more effective. It's about the injections. Ultrasound-guided injections of the long head of biceps, and I'll give you some more detail about that. More accurate, again with the ACJ sternoclavicular joint. Subacromial bursa is an interesting one that we can talk about a little bit later. So this gave a good overview of where we're at. So this is a systematic review. Sorry, it's a bit of a busy slide, but I think it's got a lot of useful information. So quite a large number, you got 800 studies. 3 studies for the ACJ said that the ACJ ultrasound-guided was significantly more accurate than landmark-guided. Interestingly, the subacromial bursa, the accuracy was better landmark-guided than for ultrasound-guided, but conversely, pain and function was improved in the ultrasound-guided. So although it wasn't as accurate, the benefit was more there. And then biceps tendon sheath, there's quite a large difference, and there is a separate study that I'll go through which shows that in more detail. It's quite a nice nuanced paper there about that. Glenohumeral joint, so 7 in 10, up to 30% are in the glenohumeral joint, and for example, glenohumeral joint you might inject for OA, often injected for frozen shoulder. So, and some people do hydrodilatations, which involve quite a volume of local anesthetic, steroid, and saline. If it's in the wrong place, it's obviously not going to work. So, with the biceps tendon sheath as well, greater reduction in pain, which would, it'd seem reasonable if 26% of them weren't in the right place versus 86%. That should correlate to a reduction in pain. So, and we go on. So the subacromial bursa, there's another study, and this is quite a nice study there. So this looked at outcomes as well. So we see with the ultrasound guided, there was a significant, this is a different study by the way, there was statistically significant difference in favour of ultrasound-guided for the pain score at 6 weeks, and also shoulder function and range of motion. So as I said before, and one of the things and the mantras were that better patient outcomes, both with pain, functioning, and this shows it quite well. So this is more about a little bit PRP, and you may get a feel that PRP is one of my areas of interest. So this just looks at using PRP in rotator cuff tendinopathy. Can reduce pain and improve range of motion. The important thing with PRP, just as an aside, in my opinion, it's not a quick fix, it's a longer term fix. So it's part of it is counselling the patient as well. That it might not get better like a steroid injection very quickly, but it should last longer than the steroid, which there's a chance things can come back. So this is the biceps tendon. This was a study that showed 86% versus 26%. And there's quite a nice study, 30 patients that were put in the two, randomly allocated into landmark guided versus ultrasound guided. Injection was done, and then it was contrast agent, and then a CT was done to locate where the injection was. And it was classified into 3 areas. Was it in the tendon sheath? Was it in the tendon sheath and peritendinously, or was it somewhere else? So in the ultrasound guided group, 86% were in the tendon sheath, 13% peritendinous, and in the unguided group, 26% were in the tendon sheath, 40% peritendinous, and a third of them were outside the tendon sheath, nowhere near the tendon sheath. So I think this shows the importance of trying to get the injection in the right place. And the next study, 45 and 53. This looked at outcomes of patients who had biceps tendinopathy, and the injection was done either ultrasound guided or landmark guided, and the degree of pain relief was statistically significantly different between the two. So obviously that then gives us that. We've got the first study that shows, if you have it, you're getting it accurately in the tendon sheath is one thing, but that also then correlates to reduction in pain. Wrist and elbow. There have been some statements with wrist and elbow, but there is limited evidence out there. So lateral epicondyle, we know that probably the only thing you should inject around the lateral epicondyle is potentially PRP, or in my NHS practice I also inject autologous blood. The days of steroid are long gone by meta-analysis evidence. Elbow joint ultrasound, I think that's more effective. I think there's different areas and different joints you can inject into the elbow joint. You could do the radiocapitellar joint or the ulnar-humeral joint as well. Again, wrist ultrasound guided injections. You can see where the source of pain is. It is tolerated better, I think, once you can visualize it and then see the needle coming in. Smaller joints, MCP, PIPJs. Occasionally I do DIPJs. I think under ultrasound guidance it's more accurate, but certainly patients find it less painful. So that's a decent paper. And this is just general evidence, some overviews for papers if somebody wanted to have a look, have a look at ultrasound guided injections, and specifically with platelet-rich plasma, from chaps who do that. The only thing I would say with platelet-rich plasma is there's a heterogeneity of different protocols, different types of PRP as well, and the production, is it activated, is it not activated, etc., etc. So take it with a pinch of salt. So this was just a systematic review, meta-analysis overall of intra-articular and peri-articular joint injections, and quite a broad statement there that the more accurate the injection, outcomes are better. So, that's I think that's been part of the mantra that you can see from the evidence, and also what happens in certainly my space clinically in real life. So I'm just going to show you a few images, and we can whip through these quite quickly. Some of these are from a sporting background. So this is a high-level sportsman with a grade 3 lateral collateral ligament injury, and there's a stump of the ligament, and then this is where there's been bleeding and hematoma. So that's at week 1. And you can see the needle visualization, the joint management with the surgeon to inject PRP into the area. So that's the needle visualization for the PRP that's being injected into the gap. And this was a protocol of weekly injections for 3 weeks. And with the eye of faith, rather than it being hypoechoic, it's mixed echoic there. So there does seem to be some new tissue formation there. And this player successfully got back to football without surgery. So a good outcome. Moving on. This is lateral epicondylitis, tennis elbow. And I've just shown you a series of images to show with PRP how you inject across the footprint of the tendon, avoiding the deeper structures where the radial collateral ligament is. So that shows it that's one needle position. And then the next 2 slides will show needle position slightly different, and then further down the footprint there. Then the next one is a hamstring. That's again into the hamstring origin, PRP. And then the next slide, I think, shows us that does not come up quite well, but that's the needle position. I wanted to show this image because if we can just go back, this image is the sciatic nerve just to the right hand side. I don't know whether my cursor is showing that, but I can certainly see that. That's where the sciatic nerve is, to the right of the screen. A painful one, Achilles insertion, PRP injection. Funny enough, I did one of those last night. So you can see the needle position there. And this is a longitudinal view of the same thing with the needle in the tendon. And that's patella tendon. You see the needle position, there's a little bit of reverberation artifact. What that is when the ultrasound waves bounce against the parallel waves and just keep on bouncing down there. So you can see the needle can be accurately seen, but sometimes if there's lots of reverberation, that can distort the image slightly. This is a ATFL, torn ATFL with, it was healing, so there's not inflammatory change around there, and I did inject into that area. It hasn't come up quite well. If we go on to the next slide, probably doesn't show it quite well. That's the needle coming in, but it's certainly not a great slide, but that was an injection into the ATFL with PRP. Knee osteoarthritis, needle position coming into the suprapatellar recess. You have the fat pad just goes under the patella tendon, and there you can just about see there is a little bit of fluid in there. So careful needle position. Just going back to that, if you didn't have the needle in the right place, you could be in the patella tendon. You could inject to the fat pad as well, which would be exquisitely painful. And so would the patella tendon. So I have to thank one of my colleagues who gave me this image. This is a muscle injury, and the black area is a hematoma that is going to be evacuated with the needle coming in from the left-hand side of the screen. Once the hematoma is evacuated, then PRP will be injected. This is injection of steroid into the first MTPJ. That is the needle. There's an effusion, and you can see the dorsal osteophyte there. So there's a little flavour of what we're doing, subacromial bursa injection. We see a lot of reverberation there. So that's the bursa there. And then, sorry, do you want to just go back slightly? So you can see the bursa there, thin line there, supraspinatus tendon there, and then you can inject into the bursa, and then it sort of almost strips off the tendon. And so, summary, hopefully we're seeing that the use of ultrasound guidance is supported by the literature, but accuracy of placement of needles, of the needle, and that equates to better outcomes and less risk. I still think there's further studies that are needed to reinforce the evidence. Some of these are consensus statements, as you can see, and some of them are relatively small studies. So I think that sort of wraps up my part of the presentation. I hope you enjoyed it. Obviously, there's always a lot of studies there, and we're presenting remotely. We've got to make most of that. Hopefully, some of the images you could see why it's important to place the needle carefully.
Great, thank you so much, Dr. Hodge. That was really good. And like I say, I think the detailed approach as well, when we send out the recording, I think those slides will be really useful for people to capture some of those research studies as well. And like I say, the visualization on some of those slides. So yeah, thank you for that. We're going to answer some of the questions, some pre-submitted questions that we got through to begin with. And again, if you are on live, please feel free to pop any questions you do have following the presentation into the Q&A, and we can check those towards the end as well. So the first question we do have, Haj, is around tips for needle visualization. So optimizing the needle and the settings on the device. So firstly, would you always recommend using the needle visualization through the ultrasound devices?
There is, I think there are on some machines you get the needle enhancement, but for me, the tips for needle visualization are you want to try and get it as parallel as possible to the beam. Obviously, sometimes it's not possible, and I alluded to the fact, with deeper structures and hips. So you want to get as in plane as much as possible. Sometimes you can even bend the needle as well. So if you're doing superficial injection, you might come at quite an acute angle, but if you bend the needle up, then that will keep it more parallel to the probe. So that's a tip. Sometimes when you have to go quite obliquely, you can have a standoff with the gel as well. So that allows you to visualize the needle even outside of the skin and coming down. Settings on the device. I think the settings on the device is you've got to have your area of interest. You've got to have, if you have machines that have a focal zone, some machines have automatic focal zones, so you're not able to sort of change that. But you're having the focal zone, having the right frequency as well. High frequency for more superficial, lower frequency for deeper structures. Getting the gain right. There's also dynamic range which can help you, and that's more the sort of black and white of the images and how grainy it is, both that with the gain. So yeah, there's some of the things I would suggest from a tips for needle visualization and optimizing that needle visualization, and also try and capture the image.
Yeah, absolutely. No, that's great. Thank you for that. One of the questions we had, obviously, a lot of the research is, very back in sort of the ultrasound guided injections, but is there any clinical scenarios that you find even in your clinical practice now about sort of the landmark sort of injection still being appropriate at all?
I think that they're definitely appropriate. Yeah, in my own practice, I don't have a departmental machine. I have a portable machine that I take with me, so that gets around not having a machine. Landmark guided injections have their place, I think, in the primary care setting. When would I do a landmark guided injection? Very infrequently, but if you don't have the machine, you have a large near fusion. That's quite easy to drain the effusion. So, That's why, yeah, I'd say, certainly landmark guided still have their place,
Yeah.
certainly.
Yeah. Okay, great. We've just had a couple of questions pop up on the live, which I'll just get to whilst these guys are on. So we just have a question about asking about PRP preparation type that you are using, Dr. Hodge. So Adam, who's asked the question, he uses Regen PRP, but thinking concentration may be too low. Any thoughts on
Yeah. I tend to use, so generally for PRP, you need at least 2 times the concentration to get a benefit. I think there is emerging evidence for that. I think the Regen lab might be lower than that. The preparation I tend to use is ACP. So that's autologous conditioned plasma, which gives you at least 2 times, if not somewhere between 2 and 3 times. There's other systems out there. I think one that's fairly fashionable at the moment is Endirect, which gives you high concentrations as well. The PRP talk could be it'd be a talk on its own, but yeah, I think I look at those systems. What you need to do is have drill down on the evidence, and certainly with PRP, and there's the emerging further evidence is that you sometimes might need to even sample what the platelet count is to know what you're getting out the other end. One of my colleagues has been doing some work in Birmingham to see what platelet concentrations are with different preparations. So yeah, it's an interesting one because I think that's where PRP also gets bad press because there's so many different preparations. I think there was when was it, 2021, where there was a study from Australia. I forgot the name of it, but certainly said that PRP was ineffective. Don't quote me, but I think that was the Regen Lab product there, which only gives you about 1.4 times. So,
Right.
all right.
Yeah, hope that answers that question there. Thank you. Just another question on the live chat is about storing the ultrasound images. So this is someone who works in a private clinic. Would you suggest a local drive or PACS?
I think if you do the local drive, you've got to encrypt things, so password protected. PACS is an interesting thing. If you're in private practice, where would you? It depends whether you're in isolation or not. If you're part of a hospital system, you can always get PACS, but I think getting PACS in a private clinic would be very difficult.
Yeah.
I certainly, keep it on the machine, but you probably have to, password protect the machine and encrypt images, etc. So,
Yeah. Okay, great. Thank you for that. So back to some of the pre-submitted questions. Obviously, you in your presentation, you did talk about sort of the different anatomical areas. One of the questions was about is there any particular areas where the ultrasound guidance offers the most significant benefit? So is there any particular joint areas that really, yeah, the ultrasound guided approach does make the biggest difference? And
yeah, as we can see with, certainly with hips,
yeah,
the accuracy is improved. Um, Tendon procedures.
yeah,
Yeah, you need to know, are you doing a tendon sheath injection or are you injecting into the tendon? Uh, for example, if you want to do a tendon sheath injection and you put in some local anesthetic in or low dose steroid or even hyaluronic acid, you want to know you're in the sheath and not in the tendon, um, because obviously injection into the tendon may cause damage. Nerve strips as well. If you're doing, I occasionally do injections around carpal tunnel, uh, lateral cutaneous nerve of the thigh as well. Very occasionally, saphenous nerve around the medial knee for intractable pain. So I think you need to know that you're perineural in the area and not in the nerve. Other injections we've already alluded to in private practice, they're expensive. You want to know you're in the right place to get optimal effect. Some of these injections are not even a few £100, they go into the thousands. So I think you need to be in the right place to get the best outcomes.
yeah. Absolutely. Great. Thank you for that. We had a couple of questions around this topic, really, just about like the training recommended, as well for clinicians transitioning maybe from landmark guided to ultrasound guided injections. Do you have any sort of suggestions or advice sort of for people looking into the development of the training pathway for ultrasound guided?
I think absolutely yes. So you can go on courses, but I think the minimum I would suggest is to do a postgraduate certificate in musculoskeletal ultrasound. You learn about the theory, you get all your scans done, you get proficient at scanning. I think you need to know what you're scanning, what's normal and what's abnormal before you start injecting. Um, but yeah, so you do that, but there's still miles on the clock. You've just got to keep on scanning. The transition from landmark to ultrasound guided can be difficult because sometimes the locations are different. And I know some colleagues will put the injection in the same place and try and put the ultrasound where they've injected, but the skill is to look at the needle. Sometimes when you're doing a landmark guided injection, you won't see the needle. For example, in the glenohumeral joint, there's no real way of seeing the needle when you're or the needle tip when you're if you put the ultrasound in line with the probe. So I think there is a learning curve with that. It comes with time. The corollary to it is you do the postgraduate certificate, but then you've still got to keep on scanning, get that fine motor control, and then have a mentor as well to sort of, somebody that can help you along the way and, get some scans under, supervision or injections under supervision.
Yeah, absolutely. I can imagine, like I say, it's about getting those hours, isn't it? As well with this sort of skill set. Some questions following within the training sort of topic was just about sort of any sort of mistakes or common mistakes that or pitfalls that people should watch out for when obviously learning about ultrasound guiding techniques, essentially. Obviously, so that transition can be quite tricky. So anything on that at all?
Yeah, I think I alluded to that in the last question.
Yeah.
You've got to try and visualize that needle, get that hand-eye coordination, that motor control as well. I remember when I first started scanning, I was like this as if it was a block of ice but it's very fine motor skills that you develop. And then you sometimes you've got to work out what's the easiest way of doing it. The ergonomics of it. Certainly when I first started doing injecting, then you suddenly realised that the machine was in the wrong place. So you've got to think of all of these ergonomics. Where's my machine going to be? Can I reach it to change, to optimize the image? I'm very right-handed, so one of my thoughts is, how am I going to get my right hand in the right place? Because I'm just about hold the probe with the left hand, but can't do any injecting with it. So I think that can be, we've already alluded to mistakes, maybe trying to inject where you do landmark guided and then putting the probe in that position. So, but it's, my own journey was, I did a PT cert, started scanning, learned how under radiology guidance how to do injections, but it still took 2 or 3 years on top of that to get really confident and competent with
Yeah.
it.
Yeah, excellent. I think you've just answered the next question as well about people just asking how long it may take for practitioners to be proficient. Like I say, and I guess it can vary obviously with the, sort of route of training, etc. But like I say, I think it's a timely skill, isn't it, really, to get it just right for
Absolutely,
competence.
yeah. I mean, some people are naturals.
Yeah.
I teach on courses, and I think, God, this guy, girl, it's like they've held probe for years. So some people are natural and
Interesting.
gifted.
Yeah.
Um, but it is hard hours. I can't say that I was gifted to begin with at all.
You worked hard. It was worth
Exactly, yeah.
it. Excellent. Okay, so I think we've just got a last few questions, and then just one sort of come up on the chat as well. Just about time efficiency, like in busy clinical settings, again, how do they compare? Obviously, landmark against ultrasound guided. That was sort of a question that popped up.
Yeah. It's a really good question because we broaden this out with my colleagues into what do you do when you see a patient, for example, in a one-stop, a one-stop clinic. You assess them, and then you might think you might offer them an injection. Uh, my own personal belief is that when you offer them an injection or an intervention, you've got to give them a cooling off period,
Mhm.
so they can make their mind up whether they want the injection or not. So, from a time efficiency perspective, in my own clinic, it doesn't make a difference because I'm I can't remember that. I don't think I'd inject anyone now first time because I want to give them time to assimilate the information. Do they have any queries? They don't feel pressurized into the situation. I set up time efficiency. I set up a dedicated guided injection clinic. So for me, that's time efficient because it's literally everything's been done in, out, in, out. So you can get the time efficiency at the back end if you want. You assess them. I saw somebody in my NHS practice the other day referred from one of my colleagues for an autologous blood injection. I spoke to them, discussed things there and then. They weren't sure. So I have quite a few patients that aren't sure and ambivalent on how to proceed. So I think for me, I just let them have a bit more time and then they can be listed straight into an injection clinic. So I think that's where I can get the efficiency. I think, in the current uh, climate, it is trying to do a one-stop shop, but I'm certainly becoming not more defensive, but more considered, I would say, with interventions on the first visit.
Yeah. Okay, great. That's perfect. Thank you for that. So the last question that's come through the chat is just about sort of the machine experience that I guess you've used. They're just asking about sort of what machine do you find the high image resolution for ultrasound guided injections, handheld versus laptop, for example. Yeah, for
Okay, I'm a purist, so I like to have the big cart-based machine wherever possible. Um, and I've used the Alpinion, which is very good. I like it because it quite, you know, different machines appeal to different people. I like quite the black white contrast, and you get that quite well with the Alpinion. Um, in my NHS practice, we use a lot of GEs. Uh, Private practice, I have a GE machine as well. Um, I sometimes toy if I'm at a sporting event with a handheld
Mhm.
device, and there's a number on the market. The first players in the market in that I knew of in the UK were Clarius.
Yeah.
There's now GE, you've got a V-scan as well. Um, there's another one I saw, Philips one as well recently. So there's a number out there. Obviously, any of these equipments, the bigger the equipment, the bigger resolution, the bigger the cost of the machine as well. So if I was going, if you wanted the biggest bang for your buck, I'd probably go for a laptop based machine.
Yeah.
You can get that for a reasonable price. So,
Mhm. Yeah, there's lots of considerations, isn't there? And like say what's right for each practitioner, especially if they are
absolutely.
new or if they're coming to learn, making that decision on what's the correct machine. But like I say, yeah, speaking to people in the field who are using the machines, or let's say speaking to us about anything like that, about queries, then that's something that, we can help with regards to the information on machines.
Absolutely. I mean, with the Alpinions, we've we've set them one up in Sheffield with various different presets, just the way you want. This is how I like my image, and been lucky enough
Mhm.
with Dominic to set that up in that way.
Yeah.
And that's the other thing, having those conversations with uh, um, the the specialists, the application specialists with
Mm.
each company, because you can set up machines in so many different ways.
Yeah. Yeah, absolutely. Great. Excellent. Well, we've gone through those questions there, which is great. Thank you very much. And I think we have got all the questions through the chat as well. So perfect. So yes, thank you very much, Dr. Hodge. Thank you for your time this evening. It's been really, really useful. Following the session tonight, we will send out the recording to everyone. So if you have missed a little bit or if you are catching up, then the recording will be available to everyone who has registered. We will send alongside a survey as well. So any feedback on these sessions will be appreciated. But yeah, if you want to get in touch with us directly as well about any ultrasound or obviously any further education opportunities, then please do so. But with that, thank you again, Dr. Hodge. And yes, I hope everyone has a lovely rest of the evening.